Thank you for inviting me, Lauren. This is a presentation that we partly gave at PAS, and I've actually reversed the order for this group because the first part of the presentation is about medical cannabis in Ohio and our hospital, and the second part is more about the study. And given that I'm speaking to a group of experts, I thought I would flip this and talk more about the study, and then if there are questions about how our clinic runs or what's going on in the United States, but I'm not sure who's in the audience and what you all want to know. And I also know that time is a consideration. So in light of that, I'm going to focus more on the actual study, but I love to frame this. I usually start my presentations with these words from Dr. Gwande, because I think everything that we do, particularly in palliative care, really needs to be focused on reducing suffering. And that's really kind of my North Star when I think about why I'm doing what I'm doing. So just in the way of disclosures, I'm joined today by two of the folks from our team, Daniel Grossamy, who's a fabulous research collaborator in our division, and Stephanie Allen, who's the nurse case manager, and really we function as a team for the clinic that we run. Luckily, Stephanie is a fantastic baker, so that if and when I get jailed for any of the practice that I'm about to tell you about, she can bake me a cake with a file in it. But just to recall that, of course, we're talking about off-label use of something, and a girl can dream to have disclosures, but I don't otherwise. The other thing to know is I'm coming from Ohio, so obviously in the United States, as I'm sure in Canada, there's tremendous state-by-state variation for all of these things that I'm about to say, so I really only am bringing forth the Ohio perspective. I wanted to start with a patient because X is really a hallmark patient that we've been working with for a number of years, and because his parents really want us to tell you his story. They want anyone to hear his story. So this is a young man that we've known for a number of years now who had very, very severe epilepsy as a result of a genetic defect, essentially. And he has a progressive disorder that was notoriously difficult to control. He had been on multiple AEDs, keto diet, which he's no longer on, has a VNS, and actually had a corpus callosotomy to try to control his seizures, but was still having multiple seizures, some of which were clinical and some of which were just captured on EEG, almost constantly seizing, and was also troubled with self-injurious and rage behaviors, was very, very easily overstimulated, and really just did not have a whole lot of quality of life. His neurology team referred him to us basically because they were kind of out of options when he was about 6. The family had started giving him CBD that they bought online, Charlotte's Web, but they hadn't actually seen any effect. And so that's part of the reason why he came to us. His mother is a healthcare provider. She works at our hospital in our oncology unit, and so has that background. So X was one of the earliest patients that we took care of. As Lauren mentioned, I've been doing this since 2018, but he really had a fantastic response and continues to have a fantastic response. And so there are a lot of pictures in this presentation of the improved quality of life that X has. He's on lots of things, and it's, from a research perspective, difficult to sort out what's causative, but his parents will tell you that his medical cannabis is the most helpful of all of his therapies that he's ever been on. And in addition to what they'd hoped for, which was improved seizure control, as we've seen with many patients, they come with one particular idea, but may notice that there are other things that are happening as a result of the cannabis, sometimes instead of the thing they were hoping, but they noticed his behavior got better, he sleeps better, he was eating better, and tolerating food better. So they really just want to be kind of shouting from the rooftops. His mother in particular is very frustrated by the legal climate that we live in and the fact that he can't have it at school and all sorts of advocacy things. So interestingly, he has a lesion on his MRI that is a glioma-like lesion that was found incidentally, and it started increasing in size until the early 2020s, and recently has stabilized. His parents attribute the medical cannabis to that stoppage in tumor growth. I, of course, am not claiming that as a success, but it's just sort of an incidental finding. So this is him in his all various ways of quality of life, and really just having a good life. Okay, so the background for our practice and the study that we're about to tell you about is, as you all know, a lot of this stuff that there's not very much literature, but it was all anecdotal. So we started the clinic here in the hospital, which is pretty unusual. Akron Children's Hospital is a freestanding children's hospital in basically an enterprise in Northeast Ohio, and we cover a large geographic area. And our palliative care team serves any child with a life-threatening condition in that geographic area. So our palliative care division is sort of the entry point for any child on medical cannabis. I want to be very clear about that. I don't just sort of open my doors and see anyone and everyone who wants or needs medical cannabis, but they have to meet criteria for our palliative care program. And just to know that almost exclusively it is the tincture formulation that I recommend. I never recommend any sort of smoking or vaping product. Rarely do I recommend gummies, depending on the child and the dose, but it's usually a mixed formulation that's close to 1-to-1 ratio of CBD and THC. So the objective of our published study was to just try to begin to identify best practices utilizing medical cannabis, and again, focused in palliative care, more from a hypothesis generation standpoint because of the paucity of literature. And we really just wanted to characterize our population in an ambulatory setting and to quantify any changes that we saw and or psychosocial outcomes from the medical cannabis or from whatever else was happening. So that was the framework that we constructed the study on. It was a mixed method study. It was a retrospective review of patients that we included from January of 2019 through the end of 2023. We are hoping to expand this and look sort of more recently and more comprehensively at all the patients we've also seen since then. It was mixed method, as I mentioned, so there was a quantitative component that was mostly done through data extraction from our electronic health record, which is EPIC, and that included the demographics as well as some clinical data about their healthcare utilization in the 12 months prior to when we first saw them and then the 12 months after, as well as parent caregiver reported outcomes, any adverse events and side effects. And we put together some descriptive statistics from this. But probably more importantly, it was the qualitative piece of this. And Daniel Grossamy, whom I mentioned, is a qualitative research expert who has been instrumental in this. But we really just wanted to get from provider progress notes any qualitative data. So not prospective, and we will hopefully do this in a more controlled way going forward. But it was, again, really just to look at some thematic analysis of the data as reported to the caregivers. So these are the demographics of our population during that period of time. You can see that it was largely a sort of young school-age population, mostly white, some African American, mostly slightly female, and mostly non-Hispanic or Latino. The diagnoses are on your right there. For the most part, oncology was a pretty strong referral source, as was neurologic and neurodegenerative disorders. And I will say that actually that is the number one referral diagnosis to our palliative care team in general is neurologic or neurodegenerative diseases. And then other diagnoses. And there could be more than one here. So the chronic pain piece could be a child with an oncology diagnosis who also had chronic pain. So the numbers don't add up when you do the math. And just to get to the money slides here. So the results that we found were pretty striking just in that small cohort. Again, we looked a year before and a year after, and one of the biggest things we found was the actual number of inpatient days was markedly reduced in that year after initiation of medical cannabis. Again, not fully taking credit for that. Correlation is not causation. Nevertheless, the data is pretty striking when you have it in front of you. And when you look at this from a cost perspective, it equated to a mean cost change of a significant amount per child per year. There were no changes in the number of general floor versus critical care admissions, but this is a pretty small group, and there was insufficient pre-post critical care data really to analyze a specific change in length of stay there. So this was surprising to us and kind of delightful. From a symptom standpoint, this is a bit of a confusing slide in the way the percentages are reported, but essentially the list on the left is what the family desired the medical cannabis for. So a lot of people come in saying they want reduced polypharmacy. As you can see, reduced pain was a big reason, and just generally increased quality of life. The percentages that are listed here are the number and the percent that achieved the outcome they were looking for. But then there's another column there that's overall reported change. So they may have had a change that wasn't necessarily what the target change was, but they still had a change that they attributed to the medical cannabis. And for a significant percentage of those kids, the last column represents the unexpected number and percentage of changes. So again, when you do the higher math here, it's a little bit confusing, but I think the main points to look at here are the fact that a good percentage of these patients achieved their target outcome, at least per their parents / caregivers. Lower numbers maybe for anxiety, but so 4 out of 11 patients who wanted reduced anxiety ended up with that, but 8 out of the cohort actually had reduced anxiety, even though that wasn't necessarily what they wanted. So again, a bit of a confusing way to present the data, but what we hoped to do with this was just to show that a lot of times, and I'm sure you've all seen this in your practice, people come in wanting something, but then they notice, other things that might be happening, and sometimes those are unexpected, but usually not a bad thing. So again, fairly striking data. In terms of the quantitative results, we did not see a whole lot of reported side effects. There were some, but they were not major, and most of the time families accommodated to them over time. 35% of patients during that year after were able to decrease or discontinue other medications. That is not a huge percentage, but what I keep in mind is that, I always think about these as being slow processes, right? When we use plant therapy, this is not something that happens immediately, and it can take a long time to know the full effects of something. And the other thing is we only proceed with decreasing or discontinuing other medications after we've achieved a stable dosing regimen on the cannabis and in collaboration with their other specialists. So that's always a later thing. So even to have seen 35% of those patients be able to experience that in that first year was striking to me. And a number of them reported improvement in quality of life and 50% improvement in at least one symptom. So again, just sort of exciting signal data, as Daniel would say. These are signals for things for us to look at in more detail. The referral sources are listed there for you. We did have a number of self-referrals, people who have heard about cannabis and wanted to come and see us, but we also had provider referrals. So some barriers that came out in our qualitative data. In the beginning, when we first started doing this, we had a lot of trouble with the products, and we still do to some degree, because obviously the tinctures are much less popular for the dispensaries to make than the high volume, money-making vaporized or smokable forms that they sell in mass quantities. So we have trouble. Sometimes families have to go to more than one dispensary. Sometimes what they've been using suddenly disappears. So that's been a barrier. And of course, because it remains federally illegal and a cash-only business, it can get to be fairly pricey depending on what the dose is and how quickly they're going through the tincture bottles. And despite it can be an additional expense that families really can't handle. But we saw a lot of things from a qualitative standpoint. This is sort of like the slide that Lauren just showed of the comments of the kids in the headache study. The parents have just really noted lots and lots of positive things, and these are just a few of the things that they told us. One of the things that I hear quite frequently anecdotally is the penultimate one there about just being able to express more emotion, engage in life more. I frequently hear families say, it's sort of like he came out of his fog or he came out of his shell, and we started to see a person in there. So that was, that's been very exciting to Stephanie and me over the years of doing this. So in general, we saw no serious adverse events or reactions. There were a number of positive outcomes reported, especially that reduced healthcare utilization, and the other things that are listed there. And of note, sometimes even when families weren't sure about whether the cannabis was doing anything when the therapy was interrupted or discontinued was when they really noticed that, oh yeah, this is actually working. We had one kid who would discontinue it for his 5 days of inpatient chemotherapy for a variety of reasons. And during that time, he would literally just count the hours until he was back out of the hospital and could restart the cannabis. We actually have a provision here at Akron Children's Hospital that kids are allowed to use their cannabis when they're in the hospital as long as their parents are giving it to them. But in the early days, we did not co-administer the cannabis with active chemotherapy because of the potential interaction and interference with chemo that is still kind of unproven. I've since gone on to kind of ignore that because for the most part, the change in quality of life and improvement in symptoms sort of merits any potential petri dish based risk that perhaps the cannabis is interfering with the chemo itself. But that is why that happened in Peter's case early on. So our end goal with this is to get to a point, this was really a first study, but to get to evidence-based guidelines to start to standardize practice, as you all were just talking about and are doing. And that's really the hope, is to carry this study into the next iteration. So we had a lot of help on this study. I mentioned Daniel and I mentioned Stephanie, without whom I could not do this clinic, and then a bunch of other people. And early on, interestingly, the Ohio Department, it was the Board of Pharmacy that managed cannabis in Ohio. It has since switched to the Ohio Department of Commerce, which I find a little bit ironic, but there was a particular person there who was very helpful in navigating what was kind of a blazing trail at the time of using this for kids. So just a lot of people that actually helped. And I've been very fortunate that Akron Children's Hospital allows me to be an employed physician and have this practice, because otherwise, my colleagues throughout the state of Ohio who work in pediatrics are actually not allowed to have the conversations that we're having. So this is what X's parents want you to know about cannabis, and I just put this up here, but his mother will frequently say they know it's not a cure, but they just are so grateful that it has helped with the quality of his days. And they've also noticed a decrease in autism. So interestingly, autism is not an approved diagnosis in the state of Ohio. We have a list of conditions that you have to have in order to qualify for medical cannabis. And there's been a fight about autism for years and years. But Ohio has not put that on the list of covered conditions. So in the case of palliative care patients, a number of these kids have autism, but they also have other diseases or conditions that qualify them for medical cannabis. So in those cases, we're able to see the impact that it has potentially on autistic behavior or self-injurious behaviors. But we're not allowed to recommend it just for kids with autism. So in the interest of time, I will stop there. I do have a bunch of other slides here just about the timeline. You can see where Ohio first approved it with the purple arrow here for medical use, and then we approved it for recreational use just in the fall of 2024, which kind of made life hard for our medical patients, interestingly, in contrast to Canada, which is way back here in 1996. So we are way behind here in the United States and have some work to do. But that just shows you where the states are in terms of approvals. You all know what medical cannabis is, so I won't go into that. But I'll stop there unless there are questions about our specific clinic or our specific practice that I can go back to, but I don't want to take up too much more time.